Bismillahirrahmanirrahim. So our next topic is stroke. So before that, we have gone through the various types of dementias, right? And we have also discussed about the headache portion. And now the next topic is stroke, right? So let's talk about stroke, right? Um, if any patient, we have to act fast if any patient have fast symptoms, like if patient is having facial weakness, F, that stands for the facial weakness, and A stands for the arm weakness. And if the patient is having speech deficit like aphasia, and time is the brain, right? So if any patient having the facial weakness, arm weakness, or speech deficit, so we have to act fast, right? So sometimes it happens if a clot is formed, so it get dissolved by our anti-clotting system that is naturally present in our body, that is protein C and S and antithrombin 3, right? So when it get dissolved, so patient will be having TIA like symptoms. So we are not gonna wait for symptoms to improve. If symptom improve by first hour, then we're gonna think about patient is having TIA, and fully patient will be having fully recovery within 24 hours, right? So if symptoms are not gonna improve, so we gonna think that the patient is having acute ischemic stroke, so we need to go for thrombolysis by retiplase, right? Okay, so we know that window period for thrombolysis is 4.5 hours, and if symptoms don't get resolved by 1 hour, so we're gonna treat this patient as a acute ischemic stroke, right? Okay. um, and normally what happens acute ischemic stroke, the CT scan, if we do the CT scan in first and second hour, it will be normal, right? All right, so we can go for the thrombolysis, right? So what happens if the very first branch of the anterior cerebral artery, that is ophthalmic artery, right? So when it is clogged, so there will be blindness, and when MC is blocked, so there will be arm weakness, aphasia, facial weakness, there could be paresthesias. If anterior cerebral artery is blocked, so there will be paraplegia, right, and paraparesis, right? If vertebral artery is blocked, so patient will be having ninth cranial palsy, right? So there will be nasal regurgitation of the fluids and nasal twang in the voice, right? So for TIA, if patient develop TIA, so we're gonna give the patient dual antiplatelet therapy, right? And it is very patient might develop the complete stroke in next 48 hours. So to evaluate that, we have got the ABCD2 score, right? So if the patient is having score of more than 6 or score of more of 7, so there's 22% chances that the patient might develop the stroke. So we need to observe this patient, right? Right, so let's talk about two more common causes of the stroke, that is called mostly we have got the ischemic stroke 80% of the cases, and 20% of the cases we have got the hemorrhagic stroke. So actually this is the most common neurological disease, right? This is the third leading of cause of the death, right? And if we define that, so focal neurological deficit due to vascular cause and event should be rapid in it should be rapid in onset and should persist for more than 24 hours. If it gets resolved by 24 hours, so we're going to call it as TIA, transient ischemic attack, right? So let's talk about the types and um, causes of the stroke, right? So we have got the two types mainly, that is ischemic stroke and hemorrhagic stroke. And ischemic is mostly because of the occlusion of the vessel, right, leading to ischemic necrosis. And hemorrhagic is because of the rupture of the blood vessels, right? So um, let's talk about etiologies of ischemic stroke first, right? So let's talk about this one. So mostly 90 to 95% of patients, we have the cause is atherosclerosis, and the second cause is thromboembolism. That is mostly from the heart, right? So if the patient is having atrial fibrillation, so there will be some clot in the left atrial appendage, so that may go up and cause stroke, right? So this is seen mostly post MI when there is stunned myocardium. So there are chances there will be stagnation of blood in the heart. So there are chances of formation of clots, and those clots are gonna go up and they're gonna cause a stroke. If patient is having ischemic heart disease, patient is having cardiomyopathy like dilated cardiomyopathy, right? So sometime it happens that patient if the patient is bedridden, so uh, DVT can go into inferior vena cava and then into right atrium if there is patent foramen ovale, right? So this DVT, this clot will go to left atria, and then this is gonna go up to the brain, and this is gonna cause the stroke. So these are called paradoxical emboli, right? So from the valvular heart, if the patient is having valvular heart disease, like patient is having mitral stenosis, so there will be LA dilation, left atrial dilation, and there will be formation, there will be clot formation in that, and that is also going to cause a, whenever there is clot formation in the heart, so it is going to cause a stroke. So like infective endocarditis, right? So those were the we have got the mycotic aneurysms, right? So if they rupture, they're going to cause the subarachnoid hemorrhage. Sometimes these vegetations pop off and they clog the blood vessels in the brain, and they're going to cause the stroke, right? In the carotids we have got atheromas, and if we talk about vasculitis, so vasculitis like SLE, antiphospholipid antibody syndrome, right, and polyarteritis nodosa, right? So these conditions can also lead to stroke, right? So we have got another cause of stroke that is called as CADASIL, right? So cerebral autosomal dominant angiopathy with subcortical infarcts, right? So it is related to Notch3 gene, right? So patient will be having dementia and migraine like illness in these patients, and patient will be having stroke features, right? So that's all about the causes of the um, causes of the ischemic stroke. We have got some of the causes on the next page, so let's talk about that, right? So sometimes it happens because of the vasospasm, right? Vasospasm of cerebral artery because of the cocaine abuse and amphetamines abuse, and sometimes it happens because of the arterial dissection, right? So we are discussing about the causes of ischemic stroke, right? So sometimes it happens because of the dissection of carotid artery. So there will be loss of flow to the blood flow to the brain, so this is going to cause ischemic stroke. And we have got atheroembolic disease, like if we thrombolize a patient of MI, if we thrombolize a patient of acute ischemic stroke, so if it mostly happens after the angioplasty, right? If we do the angioplasty, so what happens, small microthrombi may go up, and they in the brain they're gonna cause a ischemic stroke, and in the skin they're gonna cause the purple rash like features, and in the if they those clots go in the kidney, so they're gonna cause the pre-renal type of AKI, right? Renal failure, right? So that's all about the causes of acute ischemic stroke. So let's come back and let's discuss about the causes of hemorrhagic stroke. So this mostly happens because of the rupture of blood vessels. If there is mostly patient are hypertensive, if there is an elderly patient who is normotensive and there is no history of diabetes, if he get the hemorrhagic CVA, so we're gonna think that the patient is having CAA, right? That is called as cerebral amyloid angiopathy. A part of Alzheimer's disease, amyloid can also cause the weakening of blood vessels of the brain, and this when these pop off, so these are going to cause hemorrhagic CVA. So mostly it happens because there are some there is uncontrolled hypertension, if there is head injury, so the patient will be having hemorrhagic CVA. If there is extradural hemorrhage, basically we're going to discuss intraparenchymal hemorrhage, right, in this session, right. So if patient is having subdural hematoma or extradural hematoma, right, patient develops subarachnoid hemorrhage. So these are all types of hemorrhagic CVA, right. If the patient is having AV malformation, if patient is taking any drugs like warfarin, so if patient is taking drug like warfarin, so vitamin K antagonist toxicity can also lead to severe hemorrhage. So what we can do in those patients, we can give these patients the prothrombin complex concentrate. If this is not available, we can go for FFPs, right, fresh frozen plasma. And sometimes what happens, hemorrhagic CVA can also can be a presentation in a patient with who are taking NOACs, right, novel oral anticoagulants like dabigatran. So their toxicity can also lead to hemorrhagic stroke, right. All right. So and this hemorrhagic stroke can also be a presentation of the bleeding disorders, right. So if the patient is having DIC, patient is having ITP, patient is having ITP, so idiopathic thrombocytopenic purpura. So these patients can also have features of hemorrhagic stroke. So let's talk about further, right. So hemorrhagic strokes in old people is very well tolerated, as there is brain atrophy, so there is some space available. So for hematoma, right, so there will be no rise of intracranial pressures, right. So why we do CT scan in these patients, why we do CT scan patient, we need to assure that the patient is having whether hemorrhagic stroke or ischemic stroke, so that we can give these patients antiplatelets and anticoagulation, right. So initial CT scan is done to generally rule out any hemorrhage, right. So let's talk about another classification of stroke, that is, one is called complete stroke, right. Another one is TIA, with symptoms get resolved in start get resolving in within first hour, and these completely resolve within 24 hours. So if the patient is having weakness of right arm and patient is having stroke manifestations, and if we do the CT scan and it is normal, there is no hemorrhage in that. So what we can do in those patients, we are not going to wait that the patient, if the symptoms don't improve by first hour, so we gonna go straight away for the thrombolysis. We're not gonna wait for 24 hours, 24 hours to get symptoms, to wait for the symptoms so that they can completely get resolved, to make a diagnosis of TIA. But we just gonna go for thrombolysis, right, because the window period for thrombolysis in the acute ischemic stroke is less than 4.5 hours. So we're gonna act fast, right. So another one is minor stroke, right. What happens in these patients, there is recovery within 7 days. So stroke and evaluation is another type. So there is weakness and that worsens over hours to days, right. Right, so let's talk about clinical features. So we have gone through the causes of acute ischemic stroke and causes of hemorrhagic stroke. So let's talk about clinical features and let's compare both of these. Right, so in acute ischemic stroke, this is mostly sudden, can be insidious, right. So there will be premonitory symptoms like a patient will be might feel heaviness in the limbs, and patient might have slurred speech. There will be focal neurological deficits, and some mostly it happens there is no raised ICP, right. So patient will be conscious and alert, right. So in this patient will be conscious, right. because there is no raised ICP. In these patients, in hemorrhagic CVA patients, we have got the this is always, sudden onset, and there are no pre-monitoring in the symptoms, like patient don't feel any heaviness in the limbs. So in these patients there will be focal neurological deficits, and the patient will be having these signs of raised ICP, like altered state of consciousness, a headache, vomiting, fits, and raised blood pressure, right. So these are the, and patient might have the sign SUMI positive, like if the patient is having subarachnoid hemorrhage, right. So there is score for that, score for hemorrhagic CVA, right. uh, um, that is ICH score, that is called as intracranial hemorrhage score. So in the parameters are the one is the age. First one the age, the second one is the hematoma volume, third one is the intraventricular hemorrhage, fourth one is the we're gonna check whether it is infratentorial or supratentorial. It is superior to tentorium. And the fifth thing is the GCS score. So that's how we're gonna divide. If age is less than 80 or more than 80, we're gonna check these scores. uh, Hematoma volume, if it is less than 30 or more than 30, right. So intraventricular, if there is intraventricular extension, right. So if it is present or not. So if this is infratentorial or not, right. So GCS is, if GCS is between the 13 to 15 and 5 to 12, right. So basically we have to calculate the score, and this helps us to make the decision for hemicranectomy, right. So that we gonna manage these patients to lower down the raised ICP. So we have to decide for hemicranectomy, right. So this score is basically for that, right. So so that's all about the clinical features. So let's move on to the next page, right. So okay, so for investigations we can go for the CT band if it is normal, so and patient is having focal neurological deficits. So we're going to consider the patient is having acute ischemic stroke, right. So if we these features might appear after 6 hours. The in patients we can see hypodense lesions, right. In patient with acute ischemic stroke, we might see hypodense lesions after 6 to 12 hours, right. If we repeat the CT, we can get the hypodense area. So for if we get the hyperdense area, hyperdense shadow, right, hyperdense area. So this is straight away the case of hemorrhagic CVA, right, hemorrhagic CVA, right. Okay, so how to localize the lean? For that we must have a basic concept, right. Like if we talk about, this is the, right, so this is the branch, this is Sylvian fissure. We have got this motor area, then we have got this sensory area, this is the parietal lobe, right, this is the frontal lobe. We have got this here, we have got in Broca's area, right, inferior part of frontal lobe. So in the, we have got here, we have got this is temporal lobe. So in the superior part of the temporal lobe, superior and posterior part, a part of temporal lobe, and inferior to parietal lobe, we have got this area that is called as Wernicke's area, and connecting these two we have got arcuate fasciculus. All right, so there will be an artery that will be rising from here, and that is going to supply the this is the MCA, middle cerebral artery. So there will be superior vein of that, and we're gonna say this is anterior vein, and this is gonna supply these areas, right. So most of the temporoparietal region is supplied by the middle cerebral artery, right. So and we know that this area will be face, right, face will be like that, and hand will be like that, and the legs will be on the medial aspect, right. So this is basically homunculus, homunculus, right? So that is representing the motor part of the cerebral cortex. So that those legs will be supplied by anterior cerebral artery, right? So anterior cerebral artery is going to supply this area, right? Okay, so if the patient is having the cortical stroke, if the patient is having aphasia, just aphasia, like Broca's aphasia, we're going to say that this artery got occluded, right? This anterior cerebral artery got occluded, right? If patient is having Wernicke's aphasia, right? So the posterior or inferior vein of the middle cerebral artery got occluded. So middle cerebral artery itself have the four parts like M1, M2, M3 and M4, just like motorways, right? So we have got M1 to M4 part. M4 is basically gonna supply the cortex, and M2 have got lenticulostriatal branches. So I'm gonna discuss that separately, right? So if we let's talk about localization of lesion. So let's talk about some cases here. So if the patient is having sorry, if a patient is 65-year-old smoker has presented with sudden onset right-sided weakness, right-sided weakness of the leg, right, and urinary incontinence, right, and the memory loss and behavioral changes. So we have got this anterior cerebral artery that is going to supply the frontal lobe, right, and also the medial aspect of the cerebral cortex, right? So in the medial aspect of cerebral cortex, we have got those legs, right, that were dangling down. So we have got sphincters on the medial aspect. So there will be weakness of right leg, there will be weakness of legs, there will be urinary incontinence, and there will be memory loss in these patients. And if there is behavior changes, so we're gonna think that the patient is having frontal lobe lesion. So this is on the right side. So the lesion will be on the left cerebral artery, right? So this will be contralateral lesion. So in this is a case of anterior cerebral artery stroke. So if anterior cerebral artery get blocked, so we will have the features of like leg weakness, and there will be loss of sphincter control, and there will be behavioral changes and memory loss, right? So that's a case of anterior cerebral artery stroke. So let's move on to the next case, that is second case, right? So 61-year-old diabetic has presented with weakness on the right side, so lesion will be on the left side. The left-sided artery will be blocked. So like if the patient is having right-sided face, so this patient is having right-sided face, arm and trunk weakness. So this is a case of middle cerebral artery occlusion, right? So as we know that I have just made a homunculus here, that is representing a face, and this is representing a trunk, and then we have got our hands, and this area is over there on the homunculus. So this will be supplied by middle cerebral artery, right? So if it get blocked, so we will have features like face weakness, trunk and arm weakness, right? So this is a case of middle cerebral artery, and which one? Left one, because the lesion is on the right side, so opposite artery will be involved. So right, okay. So the next thing is the so this is distal MCA, distal middle cerebral artery, because if the internal capsule, if these lenticulostriatal branches are involved, so there will be also, we have got the we know that in internal capsule we have got the compacted fibers of motor and sensory pathways, right? So sensory system, so there should be some hemiparesis in these patients and hemiplegia. So how we, first thing is that if the this so this is the middle cerebral artery, right? Just let me draw this diagram. So this is M1 part, then we have got M2 part, then we got M3 part, and then we got M4 part, right? This is M4 part, this is M3 part, right? So these are the branches that are gonna supply the internal capsule, and this is gonna also supply the putamen and caudate nucleus. So this is a putamen, and we have got the caudate nucleus, right? So globus pallidus, right? So when this these lenticulostriatal arteries are involved, so there will be patient might be having hemiplegia, right? Patient will be having hemiplegia and patient will be having sensory loss. So in this case, there is just right arm weakness, right? There is no hemiplegia in this patient. Patient is having monoplegia rather, right? So this will be a case of cortical stroke. So this M4 is gonna supply the that homunculus area, right? So if it get blocked from on the distal area, so patient will be having features. Patient will be having monoplegia, right, and facial weakness, right? I hope you get the point, right? So now let's talk about another case. So this is a 71-year-old hypertensive patient who is presented with right-sided hemiplegia. So contralateral vessels will be involved. So right-sided, this is patient is having hemiplegia and hemisensory loss, right? And patient is also having homonymous homonopia because the optic tract is also going that way, right? So patient is also having aphasia. So this is a case of the proximal MCA occlusion. So since the lesion is on the right side, so left-sided arteries will be involved. So and proximal middle cerebral artery occlusion. Why it is so? Because if we occlude this artery from here, so these vessels also get involved. So patient will be having hemiplegia plus hemiparesis, right? So optic tract is also going this way, right? There's some Mears loop, right, that also gets ischemia, and the patient will be having homonymous hemianopia, right? So that's a case of MCA, right, proximal occlusion. So this was a case of MCA distal occlusion. So let's move on to the next case. A 55-year-old smoker has presented with left-sided hemiplegia. So hemiplegia, right, and hemisensory loss, right? So also having so patient is having left-sided. So right-sided vessels will be involved. So homonymous hemianopia, and he's unable to construct a star. This means patient is having constructional apraxia and unable to button and unbutton the shirt. So this is dressing apraxia. So these are the features of the of the non-dominant lobe. So that is right, our left lobe is dominant and non-dominant is right lobe most of the cases. So non-dominant proximal MCA is blocked because the patient is having hemiplegia and hemisensory loss, right? So patient is also having apraxia. Usually these apraxia features are seen with the cortical stroke, aphasia and apraxia, right? So if the patient is having this hemisensory loss and along with that hemiplegia, right, the patient is having hemiplegia and hemisensory loss, that means internal capsule is involved, so proximal MCA is involved. Let's see the case of another case. A 63-year-old hypertensive has presented with right-sided hemiplegia, right? So left is involved, hemiplegia is there, hemisensory loss is there, homonymous hemianopia is there. He cannot speak but is able to understand. So it means the patient is having occlusion of anterior division of the middle cerebral artery, right? So because the patient is having he cannot speak, right? That means Broca's area is there is Broca's aphasia in these patients, and he is able to understand. It means Wernicke's area is intact. So we're gonna say the patient is having anterior division of occlusion of anterior division of MCA. And there's another case. A 77-year-old diabetic has presented with right-sided hemiplegia and hemisensory loss. Same those features. He can speak, but he's unable to understand. Right. So in these patients, there's posterior division of the MCA is involved. So we can say that these patients is having Wernicke's area, right? So this is non-expressive. Wernicke's aphasia, This is also called as non-expressive aphasia, and in these patients there will be some meaningless speech that is called as jargon speech, right? So right, so we have discussed the various almost 6 cases here. So let's move on to the next page and let's talk about the management of the. So these were the actually these were the cases of the anterior circulation. We're going to discuss these posterior circulation stroke in the next video. So that's all for today. We're going to discuss the management part and posterior circulation stroke in the next video. So that's all for today. Okay, thanks for watching.